I'm Dr. Elena Ramirez, a cardiovascular surgeon at St. Gabriel's Medical Center, where I've spent over a decade performing intricate heart surgeries that demand both precision and calm under pressure. In this field, every incision, every suture, and every decision can mean the difference between life and death. Yet, despite the advanced technology and meticulous planning that characterize modern surgery, the operating room remains an arena of unpredictability. Comment your thoughts on the mysterious connection between patients and surgeons, and don't forget to subscribe for more captivating stories. St. Gabriel's is renowned for its state-of-the-art facilities and its commitment to tackling some of the most challenging cardiac cases in the region. Our surgical team is a finely tuned ensemble of professionals: anesthesiologists, nurses, perfusionists, and technicians, each member playing a vital role in ensuring that the complex choreography of surgery proceeds flawlessly. Over the years, I have witnessed countless procedures where years of training and experience come to fruition in moments of focused intensity, but I have also learned to respect that no matter how much we prepare, the unexpected can always intrude. Today was one of those days. As I scrubbed in and reviewed the patient's chart, I reminded myself that even routine cases require vigilance. Michael Lawson was scheduled for a heart valve replacement, a procedure that in many ways is considered standard in cardiac surgery. Michael was in his mid-50s, relatively healthy aside from his valve disease, and the plan was straightforward: replace the malfunctioning aortic valve with a bioprosthetic valve to restore proper blood flow and prevent further cardiac compromise. Despite its routine nature, every surgery carries its own unique challenges. The human body is an intricate, living system, and no two hearts are identical. Michael's preoperative tests had been reassuring, his echocardiogram clear on the extent of the valve dysfunction, and his overall health robust enough to endure the surgery. Our team had gathered in the operating room well before the scheduled start time, running through the checklist with the precision of a well-rehearsed orchestra. The atmosphere was professional but calm, the kind of focused energy that permeates every successful surgery. As I donned my surgical gown and gloves, I took a moment to center myself. Surgery is as much a mental exercise as a physical one. It demands not only technical skill, but also the ability to anticipate the unexpected and remain steady when things deviate from the plan. The sterile environment was humbling, a place where life hangs in the balance and silence often speaks volumes. Michael's vital signs were stable as anesthesia was administered, and the initial steps of the procedure began smoothly. The team worked in unison, each member attuned to the other's movements and communications. The perfusionist prepared the heart-lung machine, ready to take over circulation once we initiated cardiopulmonary bypass. The rhythm of the operating room settled into a steady pulse, punctuated by the beeping monitors and the soft rustle of surgical instruments. In my years at St. Gabriel's, I have come to appreciate that surgery is a delicate balance between control and surrender: control over the technique and environment, surrender to the body's responses and the inherent uncertainties of medicine. As the incision was made and the chest cavity opened, I was reminded of the profound trust our patients place in us. They entrust us not only with their bodies, but with their very lives, often in moments of vulnerability and fear. This trust is the foundation upon which every decision in the operating room rests. It guides us through the technical demands and the emotional weight of the work. Today, as always, I was acutely aware of the responsibility I bore, not just as a surgeon, but as a guardian of that trust. The surgical team maintained a steady rhythm, instruments passing efficiently, suction and cautery carefully used to control bleeding and maintain a clear field. The heart was exposed, its surface glistening and pulsating in time with the monitors. The malfunctioning valve was identified, and preparations began to excise it and replace it with a new prosthesis. Throughout the process, I monitored Michael's vital signs closely alongside the anesthesiologist, aware that any sudden change could signal a complication requiring immediate intervention. Yet, in these early stages, everything proceeded according to plan. The atmosphere, though charged with intensity, was one of professional confidence. In the quiet moments between critical steps, I found myself reflecting on the journey that had brought Michael to this operating room. His story was one I had heard many times: symptoms of fatigue, shortness of breath, and chest discomfort gradually increasing over months until the diagnosis of valve disease was made. Like many patients, he had endured uncertainty and fear before arriving at the decision to undergo surgery. This human narrative, often overshadowed by the clinical details, is what grounds me in my work. Behind every procedure is a person whose life we strive to improve. As the valve was carefully removed and the new one positioned, the team remained vigilant, the tension in the room palpable yet controlled. Every stitch, every adjustment, was performed with deliberate care. The success of this operation would mean not only the restoration of Michael's cardiac function, but a return to a life unburdened by the limitations of his disease. In these moments, I am reminded that surgery is both science and art, a technical mastery intertwined with a profound respect for the human condition. The operating room is a sacred space where knowledge and skill meet vulnerability and hope. It is where the surgeon's hands become instruments of healing and where every heartbeat counts. Yet, even as the procedure unfolded with practiced precision, I was aware of the invisible threads connecting us all in that room. The silent communication, the shared focus, and the collective commitment to our patient. These bonds are as essential as any scalpel or suture, forming the foundation upon which successful outcomes are built. As the surgery progressed, I felt the familiar mix of concentration and calm that accompanies years of experience. But beneath that calm lay an undercurrent of anticipation, a readiness to respond should the unexpected arise. In surgery, as in life, it is often the unforeseen that challenges us most deeply. And so, as we moved forward with Michael's heart valve replacement, I remained fully present, aware that despite all our preparation and skill, the journey was far from over. The operating room, with its bright lights and sterile surfaces, held its breath alongside us, poised on the edge of science and mystery, precision and uncertainty. In this environment, I was reminded yet again that being a surgeon is about more than technical proficiency. It is about embracing the unknown with courage, compassion, and unwavering dedication to the patient who has placed their trust in my hands. St. Gabriel's Medical Center stands as a beacon of advanced medicine in our city, a place where innovation and expertise converge to confront the most daunting cardiac challenges. Its gleaming towers and meticulously maintained operating suites reflect a commitment to excellence that extends beyond bricks and mortar. Here, every detail is designed to support the delicate work of healing the heart, from the latest imaging technologies to the seamless coordination among multidisciplinary teams. On this particular morning, the surgical unit was abuzz with a quiet intensity. Michael Lawson was the focus of our attention, a patient whose journey to this point had been marked by gradual decline and the hope of renewal through surgery. At 54, Michael was relatively young for open-heart surgery, but the severity of his aortic valve disease necessitated intervention. The valve, damaged by years of wear and calcification, threatened the efficient circulation of blood and, if left untreated, posed a risk of heart failure. Michael's preoperative workup had been thorough. Echocardiograms showed a severely stenotic aortic valve, and cardiac catheterization ruled out significant coronary artery disease. His lungs and kidneys were functioning well, and there were no contraindications to surgery. The anesthesiology team had evaluated him carefully, ensuring that the plan for anesthesia induction and maintenance was tailored to his physiology and the anticipated length of the procedure. As the surgical team gathered in the preoperative holding area, I introduced myself to Michael once again. His eyes betrayed a mixture of anxiety and trust, emotions I encounter frequently in patients about to undergo major surgery. I reassured him that our team was experienced and prepared, emphasizing the careful planning that preceded the operation. These moments of connection remind me of the human element underpinning every technical step we take. The operating room itself is a marvel of modern healthcare, an environment optimized for sterility, efficiency, and communication. Bright overhead lights illuminate the surgical field, while an array of monitors and machines hum quietly in the background, providing real-time feedback on the patient's vital signs. The room is arranged so that every member of the team has access to the tools and information needed to perform their role flawlessly. Michael was transported into this space with the calm professionalism that our nurses and anesthesiologists strive to maintain. The anesthesia induction proceeded smoothly, with the administration of medications designed to ensure unconsciousness, analgesia, and muscle relaxation. The monitors reflected stable heart rate, blood pressure, and oxygen saturation, reassuring us that Michael was tolerating the induction well. Our surgical plan was clear: perform a median sternotomy to access the heart, establish cardiopulmonary bypass to take over circulation, excise the diseased aortic valve, and implant a bioprosthetic valve. While this operation is routine in many cardiac centers, every case carries its own nuances. Michael's anatomy, previous health status, and intraoperative findings would all influence how the procedure unfolded. There is a unique rhythm to the operating room, the synchronized dance of preparation, execution, and vigilance. Before the first incision, the team conducts a surgical timeout, a final confirmation of the patient's identity, the procedure planned, and any critical considerations. This moment of collective attention is a safeguard against errors and a symbol of our shared responsibility. As the chest was prepped and draped, the atmosphere remained focused but supportive. The nurses ensured that instruments were arranged in optimal order, anticipating each step of the procedure. The perfusionist checked the heart-lung machine one last time, verifying the circuits and priming the system. The anesthesiologist continued to monitor Michael's depth of anesthesia and physiological parameters, ready to adjust medications as needed. When the scalpel finally met skin, there was a palpable sense of purpose. The incision was precise, following the midline of the sternum, and the chest was opened carefully to expose the ribcage. Using a sternum retractor, we gained access to the heart, which lay nestled within the pericardium. The beating organ was a reminder of the vitality at stake. Throughout the initial exposure, I kept a constant dialogue with the team, verbalizing the steps ahead and confirming readiness. The anesthesiology team reported stable hemodynamics, and the surgical nurses maintained a steady flow of instruments and supplies. The perfusionist prepared to cannulate the major vessels to initiate cardiopulmonary bypass, a process requiring precision and timing. Michael's heart was robust, but the aortic valve was visibly thickened and immobile, classic signs of stenosis. The plan was to clamp the aorta, administer cardioplegia to arrest the heart safely, and proceed with valve excision. Every moment was measured, every movement deliberate. The coordination here is extraordinary. The surgeon's hands operate with skill and confidence, but the success of the procedure depends on the seamless cooperation of the entire team. Each member is acutely aware of their role and the importance of their contributions to patient safety. As we progressed, I could feel the weight of responsibility settling over me, not as a burden, but as a profound privilege. To hold a patient's life in your hands, to navigate the complexities of cardiac anatomy and physiology under the constraints of time and technology, is a calling I have embraced fully. The first phase of the operation concluded without complications. Michael's vital signs remained stable, and the transition to cardiopulmonary bypass was smooth. The heart was arrested safely, allowing for a motionless field in which to work. This stillness is both eerie and necessary, a temporary silence within the beating rhythm of life. Throughout this process, I remained mindful of Michael's humanity behind the sterile drapes and monitors. His family was waiting anxiously outside, unaware of the precise moments unfolding within the operating suite. I thought of their trust, the hopes pinned on this surgery, and the future we sought to secure for him. Reflecting on the environment of St. Gabriel's, I am reminded that it is more than a hospital. It is a community of professionals dedicated to pushing the boundaries of what is possible in cardiac care. The infrastructure, technology, and expertise here provide a foundation upon which lives are saved and transformed. Yet, even in this cutting-edge setting, the human element remains central. The conversations, decisions, and moments of intuition that arise in the operating room cannot be replicated by machines or protocols alone. It is this blend of science and humanity that defines our work. As we prepared to move into the critical phase of valve excision and replacement, the team's focus sharpened. The tension was balanced by confidence, the unknown tempered by preparation. In this space, the art and science of surgery coalesce, and every heartbeat becomes a testament to the resilience of the human spirit. Michael's case, like many others at St. Gabriel's, embodies the essence of modern cardiac surgery. a discipline where advanced technology meets compassionate care, and where every member of the team is committed to the shared goal of healing. The operating room is our stage, and the patient's life is the story we strive to rewrite with skill, dedication, and hope. As the surgical team settled into the rhythm of Michael's valve replacement, a familiar sense of controlled focus enveloped the operating room. The initial stages had proceeded without incident. The sternotomy was precise, cardiopulmonary bypass initiated smoothly, and the heart safely arrested with cardioplegia. The atmosphere was one of professional confidence, punctuated by the steady hum of monitors and the subtle clinking of instruments. Every member of the team was attuned to their role, the choreography of the operation unfolding as rehearsed countless times before. Yet, amidst this orchestrated precision, an unexpected moment shattered the usual cadence. As I leaned over the surgical field, carefully excising the calcified valve leaflets, I suddenly became aware of a faint whisper, barely audible, almost as if carried on a breeze. At first, I thought it was a trick of the sterile environment, the brain's tendency to impose patterns on ambient noise. But then the whisper sharpened, and I distinctly heard my patient's name. Michael. I froze for a fraction of a second, a chill running down my spine. The voice was unmistakably real, intimate, and yet no one else in the room seemed to notice. The perfusionist continued adjusting the pump settings, the anesthesiologist monitored the vital signs, and the scrub nurse passed instruments without hesitation. No one else heard what I had just heard. I glanced around briefly, catching the eyes of my colleagues, but they were focused entirely on their tasks, unaware of the whispered voice that had broken the sterile silence. I shook my head slightly, questioning my own perception. Could it be fatigue? Stress? The intense concentration required in surgery can sometimes conjure illusions. But the voice persisted, this time clearer, more insistent. Michael. The tension in the room shifted subtly. My heart pounded, not from the surgical stakes, but from the perplexing and unsettling experience of hearing something no one else could. I signaled to the anesthesiologist, Dr. Nguyen, and asked quietly if he had heard anything unusual. He shook his head, eyes steady on the monitors, and reassured me that Michael's vitals were stable. I took a deep breath, allowing myself to refocus on the task at hand. The valve replacement was delicate work, demanding full attention. Still, the whisper lingered in my mind, a voice that seemed to transcend the boundary between consciousness and unconsciousness, between surgeon and patient. I considered the possibility that Michael might be experiencing intraoperative awareness, a rare phenomenon where a patient under general anesthesia becomes conscious and able to perceive their surroundings, sometimes even recalling events during surgery. It is an occurrence that anesthesiologists vigilantly seek to prevent, as it can cause profound distress and psychological trauma for the patient. Yet, Michael's anesthesia records showed appropriate drug levels, and his vital signs were stable, without signs of sympathetic activation that often accompany awareness, such as elevated heart rate or blood pressure. The monitors and equipment that we rely on to assess anesthetic depth had not indicated any abnormalities. Was it possible that our current monitoring tools might not always detect this rare event? The operating room, despite its cutting-edge technology, can still harbor mysteries. The interface between mind and anesthesia is complex and not fully understood. As a surgeon, I depend on my anesthesiology colleagues to manage this delicate balance, trusting in their expertise and the safeguards in place. But now, confronted with this inexplicable voice calling out from within the silence, I felt a profound sense of vulnerability, not just for Michael, but for our entire system. I shared my concerns quietly with Dr. Nguyen, who immediately reviewed the anesthesia parameters and adjusted the medications slightly to deepen sedation. The perfusionist noted the change in drug infusion rates, and the scrub nurse observed our exchange with professional curiosity. The team remained calm, focused on maintaining patient safety above all. Despite these adjustments, the whispering voice persisted intermittently in my awareness. The words were soft, sometimes fragmented, yet unmistakable. It was as if Michael's consciousness was reaching out through the veil of anesthesia, attempting to communicate in a way that no one else could perceive. This unexpected intrusion into the operating room's usual flow challenged my composure. Surgery is a domain where certainty and control are prized, And yet here was a phenomenon that defied our understanding. I felt a swell of empathy for Michael, a man lying exposed and vulnerable, trapped in a state where he could not move or speak, but seemingly aware enough to call out. I glanced at the monitors again. Michael's blood pressure was steady, pulse regular, oxygen saturation optimal. There were no clinical signs to justify the voice I heard. I wondered about the psychological impact this experience might have on him once he awakened. If he recalled these moments, would they haunt him with fear, confusion, or trauma? The operating room is a place where science, technology, and human experience intersect in profound ways. This moment underscored the limits of our tools and the mysteries that persist at the edges of medicine. I reminded myself to remain vigilant, to listen not only to machines, but to the subtle cues that might reveal the patient's condition beyond the numbers. As I resumed the delicate task of excising the damaged valve, my hands steady despite the surge of emotion, I considered the implications of what I was experiencing. How many patients might silently endure such awareness, their voices unheard by all but the most attuned? Could this phenomenon be more common than we realize, masked by the limitations of monitoring technology? The surgical team continued their work with practiced efficiency, unaware of the internal dialogue unfolding within me. The anesthesiologist adjusted the sedation carefully, maintaining the balance between unconsciousness and physiological stability. The perfusionist ensured the heart-lung machine provided adequate circulation, and the nurses maintained the sterile field with precision. Despite the extraordinary nature of the moment, I relied on my training and experience to guide me through. The operation required my full attention, every movement deliberate and purposeful. Yet, beneath the surface, I remained attuned to the faint voice, a whisper threading through the sterile air, a reminder of the patient's presence beyond the surgical drapes. This interruption, subtle but profound, challenged my understanding of consciousness and the patient experience during surgery. It reinforced the importance of empathy and attentiveness, not only to the physical well-being of patients, but to the hidden dimensions of their experience. As the valve was prepared for implantation, I felt a renewed sense of connection to Michael, not merely as a case or a procedure, but as a person whose inner world momentarily intersected with mine in a way no one else perceived. The voice that called out was a fragile thread linking us across the divide of anesthesia and silence. In that moment, the sterile operating room transformed from a place of technical mastery into a space where human vulnerability and resilience coexisted. It was an experience that would stay with me, shaping my approach to patient care and deepening my appreciation for the mysteries that lie at the heart of surgical practice. In the moments following the whispered voice I alone seemed to hear, I found myself grappling with a profound and unsettling reality. Michael Lawson might be experiencing intraoperative awareness, a rare and deeply distressing condition where a patient remains conscious during surgery despite general anesthesia. While the phenomenon is documented in anesthesiology literature, encountering it firsthand during an operation was uncharted territory for me, and it thrust the entire surgical team into an unexpected dilemma. Intraoperative awareness occurs in less than 1% of surgeries, often sparking anxiety and trauma for patients who can recall sensations, sounds, or even pain from their procedures. For the surgical team, it challenges the very foundation of trust we place in anesthesia protocols and monitoring technologies designed to keep patients safely unconscious. The thought that Michael might be silently enduring such an experience, trapped in his body yet unable to communicate, was both sobering and urgent. I immediately communicated my concerns to Dr. Nguyen, the anesthesiologist who had been managing Michael's sedation. His face mirrored a mixture of surprise and concern as he reviewed the anesthesia records and monitoring data again. Despite the stable vital signs and appropriate dosing, the possibility of awareness could not be dismissed outright. We discussed the potential need to deepen sedation and implement additional monitoring techniques, such as bispectral index monitoring, which might provide a more nuanced measure of anesthetic depth. The surgical team's dynamic shifted subtly as we acknowledged the situation. The perfusionist maintained the heart-lung machine parameters with steady hands, while the scrub nurse continued to assist seamlessly, though I sensed an undercurrent of heightened alertness among us all. The operating room, a place where precision and routine often reign, was now charged with an unusual tension born of the unknown. I felt a profound responsibility, not only to complete the technically demanding valve replacement, but to safeguard Michael's psychological welfare, even in this vulnerable state. The challenge was to navigate this complex situation without compromising the operation's success or Michael's safety. As the lead surgeon, I needed to balance focus on the procedure with responsiveness to this unprecedented circumstance. In an effort to bridge the silence and communicate with Michael, I attempted subtle gestures and verbal cues. Although he was intubated and unable to respond, I spoke quietly, telling him that we were attending to him, that he was safe, and that we were adjusting his anesthesia. It was an instinctual attempt to connect, driven by empathy and the recognition of his silent distress. The anesthesiology team adjusted the sedation, carefully titrating medications to deepen unconsciousness without inducing hemodynamic instability. It was a delicate balance. Overdosing could depress vital functions, while underdosing risked continued awareness. Continuous monitoring of heart rate, blood pressure, and brain activity became even more critical. This moment underscored the limitations of our current understanding and technology. The standard monitors had not flagged any issues, yet Michael's consciousness seemed to be slipping through the cracks. It was a humbling reminder that despite advances, anesthesia remains as much an art as a science, a field where uncertainty persists. As the surgery progressed, I found myself reflecting on the broader implications of intraoperative awareness. The psychological impact on patients who experience it can be severe, including post-traumatic stress disorder, nightmares, and anxiety about future medical procedures. Preventing such outcomes requires vigilance, improved monitoring, and patient-centered care approaches that acknowledge the complexity of consciousness. Within the operating room, the team's professionalism and adaptability shone through. We communicated openly, sharing observations and adjusting our approach as needed. This cooperative spirit is essential in moments when protocols are challenged by unexpected events. Michael's silent ordeal reminded me of the profound vulnerability patients face during surgery. Anesthesia, while indispensable, can mask not only pain but also awareness, leaving some patients in a liminal state of consciousness that is both isolating and frightening. Recognizing this possibility compels us to enhance our practices continuously. I also considered the emotional toll on the surgical team. Confronted with a rare and perplexing situation, we were called to maintain composure, apply clinical judgment, and respond with compassion. These experiences deepen our understanding of medicine's complexities and the human dimensions often hidden beneath clinical protocols. Throughout the procedure, I maintained a dialogue with Michael. Though he could not respond, I believed that this connection, however intangible, mattered. It was a reminder that beyond the technical aspects of surgery lies a profound human relationship, one that transcends words and touches the core of care. As the valve replacement neared completion, I coordinated closely with the anesthesiology team to ensure that Michael's sedation remained adequate. The monitors showed stable parameters, and the subtle whispers had ceased, suggesting that our interventions were effective. Yet, the memory of the voice lingered in my mind, a testament to the delicate interface between consciousness and unconsciousness. This experience prompted me to advocate for enhanced training and protocols at St. Gabriel's, emphasizing awareness of intraoperative consciousness and strategies to detect and prevent it. It also highlighted the need for ongoing research into more sensitive monitoring technologies and patient communication methods during surgery. The operating room, often seen as a place of precision and control, revealed itself as a space where uncertainty and mystery persist. Embracing this reality requires humility and a commitment to patient-centered care that honors both the science and the humanity of medicine. As we prepared to conclude the critical phase of the surgery, I felt a renewed sense of purpose. The challenges posed by Michael's case underscored the importance of vigilance, empathy, and adaptability, qualities that define the best of surgical practice. In the hours that followed, our multidisciplinary team would continue to monitor Michael closely, providing not only physical care, but also psychological support to address any potential trauma from his intraoperative experience. This holistic approach is vital in ensuring that patients emerge from surgery not only physically healed, but emotionally whole. Michael's case stands as a powerful reminder that surgery is more than a technical endeavor. It is a profoundly human experience shaped by trust, vulnerability, and the delicate interplay between mind and body. As a surgeon, I am humbled by the privilege of participating in this journey and committed to advancing care that honors the full spectrum of patient experience. In the midst of Michael's surgery, the operating room had transformed from a scene of routine precision into a crucible of heightened awareness and delicate communication. The whispered voice I had heard earlier was not just an anomaly. It was a silent plea, a signal from Michael's consciousness piercing through the veil of anesthesia. Recognizing this, I knew that beyond the technical demands of the valve replacement, we faced a profound challenge: how to connect with a patient trapped in a liminal space, unable to move or speak, yet somehow reaching out. With this realization, I shifted my approach. I began to attempt subtle forms of communication, aware that traditional methods were impossible under the circumstances. I spoke softly, my voice calm and reassuring, addressing Michael directly, acknowledging his presence and assuring him that we were listening and responding. Though intubated and immobilized, I hoped that even these faint cues might convey safety and attentiveness. Simultaneously, I coordinated with the anesthesiology team to carefully adjust sedation levels. The goal was to deepen anesthesia enough to prevent further awareness without compromising Michael's hemodynamic stability. This required precise titration of medications, continuous monitoring of vital signs, and readiness to respond to any sudden changes. The anesthesiologist, Dr. Nguyen, worked in seamless partnership with me, his expertise critical in navigating this delicate balance. The rest of the surgical team, though initially unaware of the subtle communications unfolding, adapted quickly as I shared brief updates. The perfusionist maintained the heart-lung machine with steady focus, while the scrub nurse anticipated the instruments needed as we progressed. The shared commitment to patient safety created a cohesive environment, even as we confronted the unexpected. Amidst this, I reflected on the emotional and professional challenges we faced. Surgery is often described as a technical pursuit, but moments like these reveal its deeply human dimension. The psychological vulnerability of patients under anesthesia, the limits of monitoring technology, and the need for empathy in the face of uncertainty all converged in this experience. I found myself attuned not only to the physical signs of Michael's condition, but to the unspoken dialogue between surgeon and patient, a connection forged through intuition, attentiveness, and respect for the unseen. This bond transcended the sterile environment, reminding me that behind every procedure is a person with fears, hopes, and a desire to be heard. The voice I had heard earlier served as an early warning, prompting adjustments that may have prevented further distress or complications. It highlighted the importance of vigilance and the willingness to question assumptions, even in settings where protocols and technology suggest certainty. As the surgery advanced, the atmosphere in the room shifted from tension to cautious optimism. The adjustments to anesthesia appeared effective. Michael's vital signs remained stable, and the whispered voice faded. The valve replacement proceeded with the precision and skill that define our team's work, each step executed with care and focus. This experience underscored the necessity of open communication within the surgical team, not only about technical matters, but about the patient's holistic experience. Sharing observations, voicing concerns, and collaborating on responses are essential to navigating unforeseen challenges. I also considered the broader implications for surgical practice. Michael's case advocates for enhanced awareness training among operating room personnel regarding intraoperative consciousness and patient communication. It suggests that integrating advanced monitoring technologies and developing protocols for subtle patient engagement could improve outcomes and reduce psychological trauma. In the quiet moments between critical steps, I continued to speak softly to Michael, reinforcing the presence of a caring team. Though he could not respond, I believed that this intangible connection mattered, that it offered a thread of comfort amid vulnerability. The teamwork displayed in that operating room was a testament to the resilience and adaptability of medical professionals. Faced with an extraordinary situation, we united our expertise and compassion to prioritize Michael's well-being on multiple levels. As the final sutures were placed and preparations made to restore cardiac function, I felt a deep sense of respect for the intricate interplay between technology and humanity in surgery. The tools and machines are indispensable, but it is the human heart, both literal and metaphorical, that guides healing. This moment in the operating room reaffirmed my conviction that patient-centered care must encompass not only physical safety, but also psychological and emotional support. Recognizing and responding to subtle cues of distress, even those only perceptible to a single observer, can transform outcomes. Michael's silent plea became a catalyst for renewed vigilance and empathy in our practice. It reminded us that beneath the monitors and protocols lies a living, conscious individual whose experience matters profoundly. As the heart-lung machine was gradually weaned and the heart resumed its rhythm, the surgical team prepared for the next phase of care. Our collective focus remained on ensuring a smooth recovery, with awareness of the challenges Michael might face beyond the operating room. In those final moments of surgery, the operating room felt both familiar and transformed, a space where science met mystery and where attentive listening extended beyond words and gestures. This extraordinary experience deepened my understanding of the delicate balance between control and uncertainty in surgery. It reinforced the imperative to remain present, empathetic, and responsive to the patient's needs in all their dimensions. As Michael's surgery concluded successfully, the lessons learned in that operating room would resonate in my practice, shaping how I approach patient care with greater sensitivity and awareness. The journey through this unprecedented moment underscored that medicine is not only about healing the body, but about honoring the human experience embedded within every heartbeat. In the quiet aftermath of Michael's surgery, as the operating room team began the meticulous process of closing and preparing for his transfer to intensive care, I found myself reflecting deeply on the phenomenon we had just encountered, anesthesia awareness. Despite its rarity, this condition casts a long shadow over the practice of anesthesia and surgery, challenging our assumptions about the depths of unconsciousness and the reliability of our monitoring systems. Anesthesia awareness, or intraoperative awareness, is a complex and often misunderstood event. It occurs when a patient becomes conscious during surgery and can recall sensory perceptions, sometimes including pain, pressure, or sounds. While protocols and monitoring technologies have advanced significantly, cases like Michael's remind us that awareness can slip through the cracks, undetected by standard measures. The psychological impact on patients who endure such experiences can be profound. Post-traumatic stress disorder, anxiety, depression, and nightmares are among the documented consequences. For many, the memory of being awake yet unable to communicate during surgery is a source of lasting distress. These outcomes highlight the critical importance of prevention, early detection, and compassionate postoperative support. Our current monitoring tools, including electroencephalography-based devices and bispectral index monitors, provide valuable insights into brain activity and anesthetic depth. However, they are not infallible. Factors such as individual variability in drug metabolism, the complexity of brain states under anesthesia, and technical limitations can all contribute to gaps in detection. In Michael's case, the absence of overt physiological signs, stable heart rate, blood pressure, and oxygen saturation, masked the subtle reality of his consciousness. This underscores a fundamental challenge: the reliance on indirect markers of anesthetic depth, which may not always capture the patient's subjective experience. The occurrence compelled me to consider the broader implications for surgical practice. How can we enhance our vigilance to detect and respond to intraoperative awareness more effectively? What protocols and technologies might better safeguard patients against this silent ordeal? These questions demand ongoing research and interdisciplinary collaboration. I also pondered the role of empathy and communication in addressing this phenomenon. Recognizing the possibility of awareness requires a cultural shift within surgical teams, encouraging open dialogue, attentive listening to subtle cues, and prioritizing the patient's psychological as well as physical well-being. Beyond technology and protocols, the human element remains paramount. The experience of anesthesia awareness is not merely a clinical event. It is a deeply personal and often traumatic encounter. Our responses must honor that reality with sensitivity and support. Within the operating room, the episode reaffirmed the necessity of teamwork and adaptability. The anesthesiology team's prompt adjustments to sedation, the surgical team's attentiveness, and our collective commitment to patient safety exemplify the collaborative spirit essential in navigating uncertainty. This event also highlighted the importance of preoperative counseling. Patients should be informed, as appropriate, about the rare possibility of anesthesia awareness and reassured about the measures taken to prevent it. Such transparency fosters trust and prepares patients psychologically for their surgical journey. As Michael was transferred safely to the intensive care unit, I contemplated the postoperative care plans that would address not only his physical recovery, but also potential psychological sequelae. Early psychological assessment and counseling can mitigate long-term distress and facilitate healing. The experience deepened my awareness of the delicate balance anesthesiologists maintain, providing enough anesthesia to prevent awareness without compromising vital functions. It is a testament to their expertise and the complexity of the human brain under pharmacological influence. Reflecting on the limits of current anesthetic monitoring, I recognize the urgent need for continued innovation. Emerging technologies, including advanced neuroimaging and machine learning algorithms, hold promise for more accurate detection of consciousness states during surgery. Yet, technology alone cannot replace clinical vigilance and compassionate care. The integration of human intuition, patient-centered communication, and multidisciplinary collaboration remains the cornerstone of safe surgical practice. This episode also reminded me of the ethical dimensions inherent in anesthesia and surgery. The trust patients place in us is profound, and we bear the responsibility to minimize harm, physical and psychological alike. In the broader context of medicine, anesthesia awareness challenges us to embrace humility. Despite advances, the mind remains enigmatic, and our tools imperfect. Acknowledging these limitations fosters a culture of continuous learning and improvement. As I resumed my duties in the surgical unit, I carried with me the lessons from Michael's case, a call to remain vigilant, empathetic, and innovative. It reinforced that medicine is not only about mastering techniques, but about honoring the humanity of those we serve. In the weeks that followed, Michael's case became a catalyst for discussions within St. Gabriel's about enhancing anesthesia awareness protocols. We reviewed our monitoring equipment, refined sedation guidelines, and initiated staff training sessions focused on recognizing subtle signs of intraoperative consciousness. These institutional efforts reflect a commitment to translating individual experiences into systemic improvements, a hallmark of progressive medical care. On a personal level, the event deepened my respect for the complexities of consciousness and the interplay between mind and body. It reinforced that every patient encounter is an opportunity to learn, to grow, and to reaffirm the core values of medicine: compassion, vigilance, and humility. The silent voice that had interrupted the surgery was more than an anomaly. It was a profound reminder of the unseen experiences patients may endure. It called us to listen more closely, to look beyond the monitors, and to embrace the full spectrum of patient care. As I prepare for future surgeries, I carry this awareness with me, ready to face the known and unknown, committed to advancing care that honors both science and the human spirit. As the surgery progressed, the whispered voice that had first caught my attention became more than an eerie anomaly. It transformed into a silent signal of distress that guided my intuition and clinical decisions. Though no one else in the operating room heard it, that faint call from Michael seemed to illuminate a hidden complication before it manifested visibly, allowing us to adapt our approach in real time. The subtlety of the situation was profound. While the monitors displayed reassuring vital signs, the voice suggested that beneath the surface, something was amiss. Trusting this intuition, I examined the surgical field with heightened scrutiny. Upon closer inspection, I detected a small but significant bleed near the prosthetic valve's seating area, an area that could have led to serious postoperative complications if left unchecked. Prompted by this insight, I directed the team to focus on reinforcing the suture line and controlling the hemorrhage with meticulous precision. The perfusionist adjusted the heart-lung machine flow to accommodate brief interventions, and the anesthesiologist monitored Michael's hemodynamic status closely. The entire team responded swiftly, their expertise converging to address the emerging issue. This moment underscored the intricate relationship between surgeon intuition and patient signals, even those imperceptible to others. It was as if Michael's consciousness, though trapped beneath anesthesia, communicated a critical message, one that transcended conventional monitoring and demanded our attention. The adjustments we made based on this unexpected insight stabilized the situation. Bleeding was controlled effectively, and the prosthetic valve was secured without further complication. This timely intervention likely prevented a cascade of adverse events, highlighting the potential value of attuned listening to subtle patient cues. Throughout this process, I felt a profound connection to Michael, not just as a patient undergoing a technical procedure, but as a person whose silent distress had been heeded. This bond, forged in the sterile operating room, reinforced the human core of surgical care. The experience also illuminated the limitations of current monitoring technologies. Despite advances, there remain gaps in our ability to detect all complications early. Integrating clinical intuition with technological data is essential, and moments like this reaffirm the vital role of surgeon experience and attentiveness. As the team completed the valve implantation and began closing the heart, I maintained communication with Michael in the quietest moments, offering reassurance even though he remained unconscious and unresponsive. This gesture, symbolic though it was, reflected a commitment to holistic care, attending to the patient's presence beyond physical signs. I reflected on the growing bond between patient and surgeon that can develop through shared vulnerability, even when one party is silent or incapacitated. This intangible connection is a powerful motivator, inspiring vigilance and compassion in ways that transcend routine practice. Postoperatively, I discussed the intraoperative events with the anesthesiology team and nursing staff. We reviewed the sequence of discoveries and interventions, emphasizing how the unusual auditory experience had prompted critical adjustments. This collaborative debriefing fosters learning and reinforces the importance of openness to unexpected signals. The incident also sparked conversations about developing protocols to better identify subtle patient distress during surgery. Could there be ways to enhance communication or monitoring that capture such silent pleas? Exploring these questions became a priority, with a focus on patient safety and psychological well-being. Michael's family, informed of the successful surgery and the challenges overcome, expressed gratitude for the team's dedication and attentiveness. Their support and trust are integral to the healing journey, underscoring the relational dimension of medical care. In the days following surgery, Michael's recovery was closely monitored. He regained consciousness without neurological deficits and expressed some fragmented memories of voices and sensations during the operation. Recognizing the potential psychological impact, we arranged for psychological support to address any residual distress. This comprehensive approach, addressing both physiological and psychological recovery, reflects the evolving standards of patient-centered care. It acknowledges that healing encompasses more than physical repair. It includes restoring a sense of safety, dignity, and trust. The experience has left an indelible mark on my practice. It reaffirmed that attentive listening, whether to monitors, team members, or subtle patient cues, is essential in navigating the complexities of surgery. It also highlighted the profound responsibility we bear as clinicians to remain open to the unexpected. In the operating room, moments of uncertainty are inevitable. Embracing these moments with humility, curiosity, and empathy enriches our capacity to provide care that honors both science and humanity. Michael's silent communication during surgery became a catalyst for reflection and growth, not only for me, but for the entire team. It reminded us that patients are more than bodies to be repaired. They are conscious beings whose inner experiences matter deeply. As I continue to care for Michael, I carry with me the lessons from this extraordinary encounter. It strengthens my resolve to cultivate attentiveness, compassion, and adaptability in every aspect of surgical care. Ultimately, this experience illustrates the profound and often mysterious interplay between patient and caregiver, a dynamic that defines medicine as both a science and an art. It is a reminder that healing is a shared journey, shaped by voices both heard and unheard. Michael's surgery concluded successfully, and as he was carefully wheeled into the intensive care unit, I felt a cautious optimism tempered by the weight of the extraordinary experience we had shared. The valve was functioning well, and his vital signs remained stable, but the complexities of his intraoperative awareness and the subtle complications we had addressed lingered in my mind. When Michael gradually emerged from anesthesia, his eyes fluttered open to a world filled with the unfamiliar beeps and soft voices of the ICU. He looked around, disoriented but alert, displaying the fragile mix of vulnerability and resilience that follows such an invasive procedure. Early neurological assessments were reassuring. His motor responses were intact, and his cognitive functions appeared preserved. Yet, in the quiet moments of observation, I noticed subtle hesitations in his gaze and fleeting expressions that suggested something beneath the surface. During our initial conversations, Michael shared fragmented memories of the surgery. He spoke of hearing voices, sensations of movement, and a whispered call of his name, details that matched the unusual intraoperative experience I had perceived. Although these recollections were incomplete and sometimes disjointed, they revealed the psychological imprint of intraoperative awareness. I recognized the importance of addressing these memories with sensitivity and care. The psychological impact of such experiences can be profound, leading to anxiety, nightmares, and in some cases, post-traumatic stress disorder. Early intervention is critical to support patients in processing their experiences and mitigating long-term distress. Our multidisciplinary team quickly mobilized to provide comprehensive postoperative care. Alongside the standard physical monitoring and rehabilitation, we arranged for psychological support, specializing in trauma related to medical procedures. Psychologists and counselors worked closely with Michael, offering a safe space to explore his memories, fears, and emotions connected to the surgery. Family involvement was a crucial component of his recovery. Michael's wife and children were briefed thoroughly on his physical progress and the nature of his psychological experiences. Their unwavering support provided a foundation of comfort and reassurance, essential for his healing journey. The ICU environment, while technologically advanced and staffed by skilled professionals, can be intimidating and isolating for patients recovering from major surgery, especially those grappling with distressing memories. Recognizing this, our nursing staff emphasized compassionate communication and emotional presence, creating an atmosphere that balanced clinical vigilance with human warmth. Throughout Michael's postoperative course, I maintained regular visits, not only to monitor his cardiac recovery, but to engage in open dialogue about his psychological well-being. These conversations were humbling and profound, reminding me that healing encompasses much more than physical restoration. Michael's resilience in facing the aftermath of his surgery inspired both his family and our medical team. His willingness to share his experiences, despite the discomfort they brought, exemplified courage and a commitment to healing on multiple levels. This case underscored the necessity of integrating psychological care into the surgical recovery process, particularly in cases involving intraoperative awareness. It challenged us to broaden our perspective beyond the operating room, recognizing that the patient's journey extends into realms of mind and emotion. In collaboration with mental health professionals, we developed individualized care plans tailored to Michael's needs, blending pharmacological and therapeutic interventions. The goal was to support his recovery holistically, addressing both the tangible and intangible effects of his surgical experience. As Michael progressed, subtle improvements in his demeanor and outlook became evident. He reported fewer intrusive memories and a growing sense of safety and control. These signs affirmed the value of early, multidisciplinary intervention and compassionate care. This experience also prompted institutional reflection at St. Gabriel's. We initiated reviews of our protocols for managing intraoperative awareness and postoperative psychological support, aiming to enhance our responsiveness to similar cases in the future. Staff education programs were expanded to increase awareness of the condition's signs and the importance of empathetic patient engagement. Michael's journey highlighted the interconnectedness of body and mind in recovery. It reminded me that while surgeons and anesthesiologists focus on anatomy and physiology, the patient's subjective experience remains central to healing. In the quiet moments of Michael's recovery, I was reminded of the privilege inherent in our work, the opportunity to witness human strength and vulnerability intertwined. His story reinforced the imperative to approach medicine with humility, empathy, and a commitment to holistic care. As Michael prepared for discharge from the hospital, we arranged continued outpatient follow-up, ensuring that his physical and psychological progress would be supported beyond the walls of the medical center. The collaboration between cardiology, mental health services, and primary care was vital in creating a continuum of care. Michael's case became a touchstone for discussions within our multidisciplinary teams, illustrating the need for integrated approaches that honor the full spectrum of patient needs. It challenged us to see beyond the procedure to the person who entrusts us with their life and well-being. Reflecting on this experience, I am reminded that healing is not a linear path nor solely a physical process. It is a journey marked by resilience, connection, and the interplay of science and compassion. Michael's postoperative course, with its challenges and triumphs, exemplifies the complexity of surgical care, a blend of technical mastery, human connection, and attentive support. As I continue my work at St. Gabriel's, I carry with me the lessons from Michael's story. It strengthens my resolve to advocate for comprehensive care models that integrate physical and psychological healing, ensuring that every patient's voice is heard and honored, even when whispered in the silence of the operating room. Michael's case quickly became more than a singular patient story. It sparked a broader conversation within St. Gabriel's Medical Center and the wider surgical community about anesthesia awareness, patient safety, and the limits of current monitoring technologies. His experience illuminated gaps in our protocols and inspired a renewed commitment to advancing both clinical practice and research in this area. Recognizing the gravity of intraoperative awareness and its psychological impact, our institution convened a task force comprising anesthesiologists, surgeons, nurses, psychologists, and biomedical engineers. The goal was to review existing practices, identify areas for improvement, and develop strategies to minimize the risk of similar occurrences in the future. One of the immediate outcomes was the implementation of enhanced monitoring protocols. We incorporated more widespread use of bispectral index (BS) monitors and similar devices, which analyze brain electrical activity to provide a quantitative measure of anesthetic depth. While not foolproof, these tools offer valuable adjuncts to traditional vital sign monitoring and can help detect subtle signs of consciousness. Training programs were expanded to educate the entire surgical team about the signs and implications of intraoperative awareness. Emphasis was placed on fostering open communication channels, encouraging staff to voice concerns promptly, and promoting a culture where patient-centered vigilance is paramount. Beyond technological and educational initiatives, we developed standardized protocols for postoperative assessment of patients at risk for awareness. This included routine psychological screening and timely referral to mental health services when indicated. The integration of psychological support into postoperative care plans aimed to address the emotional sequelae proactively, reducing the incidence of long-term trauma. Michael's case also prompted collaboration with external research groups focused on the neurophysiology of anesthesia. Together, we explored emerging technologies, such as advanced neuroimaging and machine learning algorithms, which may one day offer more precise and individualized monitoring of consciousness during surgery. At St. Gabriel's, these efforts culminated in the establishment of a multidisciplinary anesthesia awareness committee tasked with ongoing surveillance, quality improvement, and research promotion. This committee serves as a model for integrating clinical insight, patient safety, and innovation. The ripple effects extended beyond our institution. Michael's experience was shared at regional medical conferences and in peer-reviewed journals, contributing to the broader discourse on anesthesia awareness. These forums facilitated knowledge exchange, encouraged reporting of similar cases, and underscored the need for systemic enhancements. Within the operating room, the lessons learned translated into tangible changes in practice. Anesthesiologists adopted more nuanced dosing strategies, tailoring anesthesia to individual patient physiology and risk factors. Surgeons and nurses became more attuned to subtle patient cues, fostering a heightened state of collective awareness. Importantly, the culture shift emphasized empathy and patient advocacy. Recognizing that patients may silently experience distress during surgery reinforced the imperative to treat each individual with compassion and attentiveness beyond the technical demands of the procedure. Michael's family, involved throughout his care, became advocates for awareness and psychological support initiatives. Their voices added a vital dimension to the conversation, reminding clinicians that patient experiences extend far beyond the operating room. This holistic approach to patient safety reflects evolving standards in healthcare, embracing complexity, interdisciplinarity, and patient-centered values. It challenges us to see beyond protocols and machines to the lived realities of those we serve. Reflecting on these developments, I am struck by the power of individual cases to catalyze systemic change. Michael's journey transformed not only his life, but also the practices and attitudes of an entire medical community. As a surgeon, I am humbled by the responsibility and privilege to be part of such transformative work. It reinforces the necessity of continuous learning, openness to new insights, and commitment to holistic care. The integration of psychological care into surgical recovery plans, the enhancement of monitoring technologies, and the cultivation of empathetic team dynamics represent steps toward safer, more humane surgical environments. Michael's case remains a touchstone in our ongoing efforts, a reminder that vigilance, compassion, and innovation must go hand in hand. As I continue to care for patients at St. Gabriel's, I carry the lessons of this experience with me, advocating for practices that honor the complexity of human consciousness and the full spectrum of patient needs. Ultimately, the story of Michael Lawson is a testament to the dynamic interplay between individual resilience, clinical expertise, and systemic progress. It exemplifies how medicine evolves through reflection, collaboration, and unwavering dedication to patient well-being. As I reflect on Michael's journey, from the quiet whisper that interrupted his surgery to the profound changes his case inspired, I am reminded of the delicate balance medicine must maintain between knowledge and mystery. His experience is a humbling testament to the limits of our understanding and the unseen dimensions of patient care that challenge us to be ever more attentive and compassionate. Medicine, especially surgery, often feels like a domain of precision and control. We rely on evidence-based protocols, advanced technology, and rigorous training to navigate the complexities of the human body. Yet, Michael's story reveals that beneath this veneer of certainty lies a world where consciousness, perception, and human experience can defy explanation and escape our instruments of measurement. The voice I heard in that operating room, intimate and profound, was a stark reminder that patients are not merely bodies to be repaired, but individuals with inner lives that persist even when the body is immobilized and sedated. It underscored the importance of empathy and the need to listen deeply, not only to monitors and metrics, but to the subtle cues that may reveal hidden realities. This encounter challenged me to confront the boundaries of medical technology and the humility required in our profession. Despite the marvels of modern anesthesia and surgical technique, some aspects of consciousness remain elusive, reminding us that medicine is as much an art as a science. The lessons from Michael's case have permeated every aspect of my practice. I approach each patient with heightened awareness, mindful that beneath the clinical presentation lies a complex human story, often silent, sometimes fragile, but always deserving of respect and care. At St. Gabriel's, Michael's experience has sparked a cultural shift. Our teams now embrace a more holistic view of patient safety, one that integrates psychological well-being with physical health. We have fostered environments where multidisciplinary collaboration thrives, where anesthesiologists, surgeons, nurses, and mental health professionals work in concert to address the full spectrum of patient needs. The development of enhanced monitoring protocols and educational initiatives reflects our commitment to learning and adapting. But beyond protocols, it is the cultivation of empathy and attentiveness that truly transforms care. Recognizing the patient's voice, whether spoken aloud or whispered in silence, is central to this transformation. Michael's resilience and the unwavering support of his family have been a source of inspiration. Their journey through uncertainty, pain, and recovery embodies the human spirit that medicine seeks to serve. Their story reminds me that healing encompasses hope, dignity, and connection, As I continue to navigate the complexities of surgical care, I carry with me the profound awareness that every procedure is not just a technical endeavor, but a deeply human experience. The intersection of mind, body, and technology is fraught with challenges, but it is also rich with opportunities for compassion and understanding. The unseen voice that broke through the sterile silence of the operating room is a symbol, a call to remain vigilant, to honor the mysteries of consciousness, and to embrace the uncertainties that define our work. It is a reminder that medicine is a shared human endeavor, one that requires courage, humility, and an unwavering commitment to those we serve. Ultimately, Michael's journey stands as a testament to the enduring pursuit of understanding that defines us as physicians and caregivers. It challenges us to blend scientific inquiry with compassionate care, to listen beyond words, and to hold space for the full humanity of our patients. In this delicate balance between knowledge and mystery, I find both the challenge and the promise of medicine, a field forever evolving, shaped by the stories of those who entrust us with their lives and by the quiet voices that remind us of the depth and complexity of the human experience.